Hello, this is Dr. Bhomik. Today I'm going to discuss a subject which is not commonly discussed in the regular lecture called diabetes insipidus. I have divided this talk in two parts, mainly because the attention span of the people are not very long, about 20 minutes, maybe at best 30 minutes. And plus, this is not something you hear uh, or see the patient voice every day or not very frequently. See, that's what I have divided in two parts so that we can go slowly. And there are two types of diabetes insipidus. Diabetes insipidus, it could be central, and that due to the deficiency of antidiuretic hormone, or it could be nephrogenic diabetes insipidus where there is plenty of hormone but the nephron does not respond, or pitocin resistant, radiase resistance. Now, in layman's term, they call diabetes insipidus is water diabetes and diabetes mellitus is sugar diabetes. And actually that is true. Now, before we go to any further discussion, let me discuss a little bit about the ADA's physiology. Obviously, this is not going to be very brief, that the one that we really need to know. ADAs is synthesized in hypothalamus, in supraoptic and paraventricular nucleus, and then there is a formation of the granules by the neurohypophysin, and then it goes down through the long axon to the posterior pituitary, and that's where it remains stored. And so posterior pituitary is a storehouse. I think this diagram is the best way that I can explain. So we can see that paraventricular and supraoptic nucleus, and then these granules that trickle down, they come through this axon and stored in posterior pituitary. And just to add, the oxytocin also being secreted from there and come and stored in posterior pituitary. And let's talk about the mechanism of action of antidiuretic hormone. The receptor for ADAs is located in distal convoluted tubule collecting duct of nephron. It has two receptors, one is V1 and V2, and I have a nice diagram next slide to explain all that to you. And that activate the adenyl cyclic AMP system, and as a result there will be increase in the membrane pores size, and therefore more water can be reabsorbed from the collecting duct and distal cortical nephron. And again, this is a very good diagram. And so these are the things like sympathetic stimulation, hyperosmolarity, hypotension. These are the stimulus to release vasopressin from there. So it can go either to V2 receptor, and if you go to the V2 receptor, and that's where what is our diabetes insipidus we're talking about, there is a renal fluid reabsorption and increased blood volume. On the other hand, V1 is used for receptor is used when it has to produce vasoconstriction and increase arterial pressure. So as that previous diagram showed, that increased secretion of ADAs happen in certain situations. Therefore, the decreased secretion of ADAs will also happen in a very reverse situation if there is a hypervolemia, hypoosmolarity, hypothermia. In this condition, the body needs to dump more water. And obviously, if somebody has developed diabetes insipidus, clearly that will result in profound urine output. And alcohol, anticholinergic drugs, and some other drugs, especially alcohol, people knows that if you drink a little too much, you need to go to pee. So, what happened when somebody has diabetes insipidus in terms of symptomatology? Polyuria, polydipsia, and failure to thrive, constipation, and inadequate perspiration is a really good clinical hallmark of hallmark of ADH deficiency or diabetes insipidus. And about 60% may have abrupt onset, but in certain cases, the onset is gradual and insidious. And the symptoms vary with the degree of ADH deficiency. In the beginning, it could be partial diabetes insipidus, but as the time goes, it could be more or less complete diabetes insipidus, and the symptom definitely will be more aggravating. So, diet and renal function and thirst mechanism also plays a role. How virulent is this polyuria and polydipsia is going to be. And if you look at some of the symptomatology and with some very ominous clinical finding like visual field defect, abnormal pupillary response, and upward paralysis of the upward gaze of the pupil, and that is very alarming, and that could be the sign of brain tumor, hypothalamic dysfunction, etc. So, confronted with the diagnosis of diabetes insipidus, what one can do? In the office, you can get a quick serum, a quick urine osmolarity, and the lab also can tell you the serum osmolarity very quickly. In addition to that, serum electrolyte is very important. Measurement of serum sodium, potassium, urine osmolarity, urine sodium, and these are the basic things that can be done in the clinic. If somebody has got urine osmolarity more than 600, urinary sodium more than 20 milliequivalent per liter, and has got normal electrolyte, normal sodium, that is very comforting, and that make the diagnosis of diabetes insipidus unlikely. At the same time, if somebody is suspicious of DI, then it's always a good idea to check the thyroid function, serum cortisol, creatinine, kidney function before a definitive test is done. There is always a question, which one is better? Is it urine osmolarity versus urine specific gravity? Urine specific gravity, as I like to call, is the poor man's urine osmolarity, but it is not the best, because urine specific gravity correlate directly with the weight of the solids in the urine. On the other hand, urine osmolarity is proportional to the number of the molecules. So molecular weight does not change the osmolar effect, and therefore urine osmolarity is a better test than a specific gravity, and I think that should answer the question if urine osmolarity is a better test. When you are getting the history and some of the laboratory finding, you will see the urine volume could be anywhere between 5 to 10 liters per day or even more. There are literature suggests they can have gone up to 20 liters per day. But urine specific gravity without presence of protein or glucose, abnormal solids, is going to be less than 0.1005. Urine osmolarity is 50 to 200 milliosmol, and serum osmolarity also increased to high normal, and the electrolyte wise, it is important. The electrolyte wise, they have hypernatremia, could be a mild degree, or if the patient is drinking enough fluid, then you may have upper normal sodium, but certainly is not going to be low normal. Okay, so that is important. If somebody do ADA's concentration, clearly is going to be low. There are secondary cause of central diabetes insipidus, and those are the one is associated with significant morbidity as well. So secondary cause, that one that we really worry about, that hypothalamic tumor. You have heard about histiocytosis X or Hanschler-Christian disease, granulomatous disease, sarcoidosis, tuberculosis, etc. And it can happen after meningitis, encephalitis, aneurysm, thrombosis. Okay. And trauma, both surgical or accidental trauma, also can give diabetes insipidus. And actually, if the patient has significant head trauma and develop diabetes insipidus, the prognosis is not very good. And in addition to that, autoimmune neurohypocrytis may also, which is extremely rare, that I have not seen one, and then congenital malformation, that what we call a septo-optic dysplasia, and that's a midline septal defect, and that's actually is diagnosed even in the newborn period by strabismus, and they may have other hormone deficiency as the time goes. So time-honored water deprivation test is still the best way to go, and the deprivation test starts in the morning, but it should never be more than 5 or 6 hours. So if after this water deprivation test the urine continue to be diluted and serum osmolarity also go more than 290 millismol per kg, and then weight loss more than 30% after the test, then about 10% rise of urine osmolarity after administration of short-acting ADAs like lysine, vasopressin, then you will consider the water deprivation test is positive, and diagnosis of central diabetes insipidus is very likely. So again, persistently diluted urine, serum osmolarity, weight loss, and urine sodium, and rise of urine osmolarity after administration of short-acting pitocin. This will be all point towards a positive water deprivation test. Now, this is a board question. It's usually we like to separate who makes like 85, 90th percentile, but it is a very valid and justifiable board question. And if you remember that if there is a destruction of supraoptic and paraventricular nucleus, then the DI will be permanent, and that takes no brainer because that's where they come from. They're synthesized there. Destruction of neurohypophyseal tract that's come through the median eminence, and if there is a lesion or there is a destruction of neurohypophyseal tract, the above median eminence, the result will be also same, a permanent diabetes insipidus. However, division of the tract within median eminence or below, the DI will be less severe or may not be clinically that much. Destruction of the posterior pituitary or surgical removal also result in transient DI and asymptomatic concentration defect. So they won't need any treatment or anything, but they probably will go to the bathroom a little bit more than the other people, but it's not something that will be a significant problem. So as I said, this is the median eminence, hypothalamus, and the posterior pituitary, and this diagram is to show the effect of concentration defect depending upon the site of the lesion. There is one thing that also comes in your examination, if not in pediatric, but certainly pediatric endocrine board examination is a very fair question. And after a surgery in hypothalamic pituitary area or secondary to trauma, initially there may be polyuria for polyuria that might start about 1 or 2 days after the surgery or events, and it may last for 3 to 5 days, and that is believed because of the local edema. However, interface is the confusing phase. You may have a normal urine output and abating of the symptoms of DI after those 5 days and looks like nothing has happened, and that could be due to the recovery from edematous area or could be degenerating posterior pituitary which was releasing the ADH to the circulation just to die, and in that case the DI will be permanent or complete. So these 3 phase, initial polyuria, then interface, then either the patient recover from the DI or become permanently DI. That will depending upon the insult. I like to end the discussion at this part, and I'll continue the rest of the discussion about DI and nephrogenic DI in my next lecture.